Hello friends and welcome to the channel again. I am Dr. Mohsen Raj Mantu. I'm a DM cardiology student at AIIMS Delhi. I've completed my MD from AIIMS Delhi. And this is the third video on the ECG lectures. This is about QT interval. So after this video, you will not have any confusion how to calculate QT interval, how to correct it for the heart rate, and why is it important. So you've seen this picture before. I want you to specifically focus on what exactly is QT interval written here in the blue. So from the onset of the QRS complex, right here, from the onset of this QRS complex to the end of the T. So as I've told you previously that this actually represents the combination of ventricular depolarization and repolarization. This is the overall the ventricular electrical activity, depolarization and repolarization, right? So this is QT interval from the onset of Q to the end of T. Now, many a times it becomes difficult on an ECG to exactly find where the T ends. So a key at that point of time is to take a tangent to the maximum slope of the T wave and see where it touch the electric baseline, the isoelectric line. So that point is taken as the end of the T. So from the onset of the QRS complex to the end of the T, or the slope where it meets the isoelectric line. This is the QT interval. The next thing that is important for you to understand that this QT interval will vary with heart rate. So heart rate, depending on the heart rate, if the heart rate increases, QT interval will change. So that is why we need to correct the QT interval, which is depicted as QTC or QT corrected. And this is corrected for the heart rate. And this is one of the many formula, but this is the one that we routinely use for correcting the QT interval. So this is the QT that you measured divided by square root of the RR interval, which is a measure of heart rate. So let's apply it to an example. So in this situation, you measure the QT interval. So this is the measured QT interval from the onset of Q to the end of T. So here again, it has been drawn as a tangent to the maximum slope of the T and see where it touches the baseline. So we have measured QT interval as 420 milliseconds or 0.42 seconds. Remember the basic rule, one small square is 0.04 seconds or 40 milliseconds. So you can count the number of small squares and then we have measured it. It is 0.42 seconds. So you write the 0.42 in the numerator and then you check the RR interval in seconds, right? So again, you have to measure the number of small squares or the number of large squares and see how much is the time interval between the peaks of the two RR. The peak of this R wave, the peak of this R wave, and count the number of small squares and multiply that by 0.04. That will give you the RR interval. You do this simple mathematics and you'll find that here the answer using the Bayes' formula is 0.428. So it is simple. In any situation, you're given an ECG or in your ward, you have the ECG of a patient, just practice it once from the onset of Q to the end of T, measure it in seconds, then divide that by square root of RR interval. That will give you the corrected QTC by this Bayes' formula. And what is normal and abnormal? So the normal value is 450 or 460 milliseconds. This is the upper limit. So if it's more than 460 milliseconds in females or more than 450 milliseconds in males, then you call it prolonged QTC. And what is a short QT interval? It's differently reported. Some people say it's less than 360. Some people say it's less than 390 milliseconds. But roughly you can say the normal value of QT intervals may be 350 to 450. Beyond 450, it's a prolonged QT. Less than 350, it is a short QT. Now here I encourage you to always calculate the QTC, but as a kind of a thumb rule or a quick screening method, see if the QT is more than half of the RR interval, just on looking at the ECG, if you see that the QT interval looks more than half of the RR interval, it's prolonged. And a normal QT is always less than half the RR interval. This is the normal QT. QT is less than half the RR interval. Just imagine, look at the RR interval, see how long it is, and look at the QT interval. It's definitely less than half. So it's normal. And if it's more than that, it could be prolonged QT. But this is just a screening. This is just an eyeballing method. You have to calculate the QTC using the Bayes' formula. So what are the causes of prolonged QT? You can read about that from the book. The video is not meant for that. It is just the practical tips on ECG. But remember, there are congenital causes, there are acquired causes. Congenital causes we'll discuss separately, congenital long QT syndromes, but common acquired causes are electrolyte abnormalities, including hypokalemia, hypomagnesemia, hypocalcemia, drugs, including different antiarrhythmic drugs, and there's a separate list. You can check it on any website, or any, just type it in Google, drugs causing QT prolongation. You'll see lots of these drugs. Okay, don't forget these tricyclic antidepressants and these antipsychotic medications. And remember, acute myocardial ischemia will prolong QT interval. Acute myocarditis due to any cause will prolong QT interval, and an important cause of QT prolongation is bradycardia, especially complete heart block or advanced AV block. So this is an example. I'm not teaching you this stuff, but type it in Google, see what drugs prolong QT interval, and these drugs have to be avoided in a patient with prolonged QT interval, because if you give such drugs, that can predispose patients to a dangerous ventricular arrhythmia known as torsades. We'll discuss that in a subsequent lecture on ventricular arrhythmias. Now coming to the congenital long QT syndrome, see, these are cardiac channelopathies, which are abnormalities on the channels that orchestrate the cardiac action potential. And again, this is not meant for an MBBS student, all these different names of congenital long QT syndrome. There are so many mutations in potassium channels, mutations in sodium channels or calcium channels. I don't want you to remember this, but for the purpose of exam, remember these two syndromes. The Romanov-Watt syndrome, it's an autosomal dominant form of a congenital long QT syndrome, and Jervell and Lange-Nielsen, this is an autosomal recessive variant, and this is the one that's associated with sensorineural hearing loss. So if you will have a question in exam, in NEET, it would be something either Romanov-Watt, which is autosomal dominant, and Jervell and Lange-Nielsen, which is autosomal recessive. So this finishes this short video on long QT, the QT interval and how we calculate it. See you in the next video.